You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is John Oertle. He's working on genetically targeted fractionated chemotherapy called GTFC and chemoimmunoprecision injection, CIPI. He's the Chief Medical Director at Envita Medical Centers, ENVITA. So welcome, John. Going to talk about what you do there.
Hey, it's a pleasure to be able to be with you today.
Yeah, well, what I just said that you do is sounds very technical. Before we get to that, just tell me a bit about yourself, how you got to Envita, and then we'll go into the technology.
Yeah, great. So a little about me. I'm the Chief Medical Director at Envita Medical Center. We're a center of excellence for cancer and really difficult to treat chronic disease and neurological and autoimmune diseases. I think we're going to focus specifically on our cancer program we have today with those technologies. But yeah, we live out here in beautiful Arizona. At least it's beautiful this time of year. Not so much always. But yeah, it's beautiful out here. And I've been, born and raised out here in Arizona. Have a wife and 5 kids, and they keep me busy, and the practice is thriving. We've got 35 docs in our practice, and I oversee the medical care and the technology that we bring on into Envita, and we focus on outcomes. We focus on being able to treat people and get them well. And so it was founded by Dr. Dino Prado 25 years ago, and he's the CEO of our company, and he continues to be able to grow and expand the actual work we do. But when it comes to, it's always been about the focus of the outcomes to be able to get these difficult to treat diseases and getting patients well and back to their families. And so to be able to share with some of the technology that we have to be able to do so.
Okay, well, within the cancer world, you said that's a focus. Are you treating rare cancers, liquid cancers, solid tumors? Where in the cancer world are you guys attacking, and what's the technology to do?
Yeah, great. So yeah, we treat solid tumors at Envita in our Center of Excellence. 80% of our patients come outside of the Arizona, and 20% actually come from across the world to be able to come to our Center of Excellence in Scottsdale. And what we do, it's a unique to be able to treat. We do treat, again, very common breast cancers, but we also treat really rare genetic diseases as well, more of a unique cancers, or even undiagnosed primary cancer tumors. And the way that we do it, though, is very unique. It's actually working on the genetically targeting the actual treatment to the actual patient specifics themselves. And this is a part of what we do. We'll talk about the GTFC, or the genetically targeted aspect of that cancer, the chemotherapy treatment, because where we're unique is that instead of just a one-size-fits-all approach to a cancer patient, which is actually what happens right now currently in our society, is that people are getting, even if you go to some of the best leading medical centers nationwide, you're still getting a one-size-fits-all medical oncology approach, because this is what your insurance company is going to be covering. So if you have, say, for instance, stage 4 colorectal cancer, you're going to get the same regimen because this is what your insurance company is going to cover, and this is what the national guidelines actually share that you should be able to start with as far as your first-line therapies or your second-line therapies. And you can't really differentiate until you actually are getting then finally into clinical drug trials. Well, so for us, we actually say, yes, we love the population studies. I love the actual National Comprehensive Cancer Network guidelines. And we look, and those are a part of our algorithms that we actually utilize to select chemotherapy targets. But where we're different is that we actually are saying, if you have, chemotherapy that's showing effective for you, that is maybe a breast cancer chemotherapy, but you have colorectal cancer, well, we're going to start to utilize some of these therapies and putting them together to be able to create the actual cocktail that's designed around your specific cancer. And so that doesn't happen in the conventional system. And so for us, we take thousands of these biomarkers to be able to look at targets, both in the tumor itself. So we do biopsies of the tumor, and we look at these molecular targets on the tumor. We also look at the liquid biopsy, looking at the bloodstream, because there's technology now that, again, exists where you can actually see DNA coming from the cancer that's floating around in the bloodstream.
Is it DNA, or is it like the packages of extracellular vesicles, or what is it?
We use DNA. We use extracellular vesicles. We're using mRNA and the actual RNA transcriptome. We're also looking at circulating tumor cells, so the full cells that are the cancer cells that are floating around in the DNA or in the bloodstream as well. And we're also looking at other metabolites in the body, looking at inflammation, looking at the growth factors of those what's being produced by the actual cancer to be able to grow tumors. We're looking at metabolism, because metabolism plays a role in the actual cancer continued growth. And so we're looking at all those metabolites and those actual factors to be able to then put forth our plans specifically for that patient. And it includes the actual chemotherapy, but it also includes maybe, say, for instance, non-chemotherapeutics as well, because they're having certain targets, like being able to utilize other medications off-label, vermectin, doxycycline, celecoxib, or Celebrex for anti-inflammation.
Out of all these factors, I would think there's a few that are probably very important, and other ones that maybe are more fine-tuning. What are you able to say which biomarkers or which factors have a big part in the algorithm and why?
Yeah, we do. It's interesting because we're continually finding and we're refining our own data as well. So when we collect the data, we're actually continuing to find which ones have more clinical relevance than others out of those thousands. What's interesting, though, is that it is really a dynamic of, there's some chemotherapy, even something as far as, so I'll give this example because, again, break it down as far as, something as simple as HER2 positivity. So if you have breast cancer, you're going to get the targets of estrogen receptor positive, progesterone receptor positive, or is it HER2 positive? What this is HER2 positivity is a growth factor that actually stimulates rapid growth on the actual tumor. And so before we had treatments for that, again, breast cancers that had that HER2 positivity were very deadly because they spread really rapidly, and it was a very deadly cancer for patients. And then we came up with, pharma came up with the actual ability of having a medication called Herceptin. And now we have other agents that actually help, build with Herceptin that actual target as well to be able to silence that. But it's been life-saving for breast cancer patients. Well, we look at that, and this is an amazing drug target, but again, it's on other cells beyond just breast cancer. And so when it's found on a colorectal cancer, say, for instance, because it is on a certain percentage of time, again, we're putting that algorithm, that smart drug, into that actual algorithm. And it's been profound and beautiful. And we use that with other things as well. I don't want to say that it's only the chemotherapy, because there's other, you want to silence the cancer cell where it's actually continuing to grow. And there's so many mechanisms that a cancer cell uses to be able to grow. Yes, growth factors are one of them, or that endothelial growth factor, that HER2 positive is just one of those many agents. But there's also these other ways that a cancer cell likes to invade and grow and find a way around. And this is where, again, when you don't have chemo agents that actually target all those ways that a cancer likes to be able to find a way to get around treatment. And one of them, say, for instance, is a molecule called MMP9. This is a molecule that takes that extracellular matrix and continues to be able to create inflammation. And it has a poor prognosis if this is present. And one of the best ways to be able to silence that is through, like I said, celecoxib, or the Celebrex, which is the anti-inflammatory medication. And so this is where, if that's there and you don't have a chemotherapeutic that actually targets it, you can use these other off-label medications that actually target that. We also use other natural agents as well that, again, maybe there's not another full therapy that actually, chemotherapy, other medication. And so this is where you go into the more of the natural world, and you see things like curcumin or quercetin that have other targets for these other therapies as well. What's interesting about those natural agents is the fact that, again, that these are not going to be a one-size-fits-all, because what we do is we put these natural agent targets into our program, but only if you have targets for it. So where a lot of people are saying, again, really excited about curcumin being a therapy for cancer. And I always like to be able to caution, to be able to say, well, does it work with the drugs in which you are being prescribed? And then two, is it actually a therapeutic target for your specific cancer? Because not all cancers respond to curcumin, but some do have specific targets that you can actually benefit. It's interesting when sometimes people have resistance to chemotherapies, even with like a cisplatin resistance, which is a platinum-based chemo, and you're starting to find resistance. There's actually some data where if you have a specific biomarker target it's a miRNA, it's a factor that's starting to be able to show that the resistance of the cancer is starting to build to cisplatin or to this chemotherapy that the body has been given. It was sensitive and now it's building a resistance pattern. Well, then you can start to give curcumin that starts to be able to turn it from being resistant to becoming sensitive again. And it can turn on an agent that was, showing resistance patterns that the body's now, again, it's now starting to be able to respond because you've been catching it in real time.
It happens when you're attacking the cancer in multiple ways instead of just one, with one chemical pounding it over and over and over. What is this best used post-surgery? Is this best used, as chemotherapy or as an adjuvant to it? Like, where does your protocol come in where it really does a lot of good?
Yeah, so you can use it with surgery. So many times we do, and we are actually analyzing that. You can use it after surgery or before surgery as far as trying to be able to say, if you have a really large tumor and you want to be able to shrink down that tumor, yes, it's good to have those targets and then evaluate it to get that actual tumor out. Many times smaller tumors, the body will just reabsorb the actual tumor, so you don't need to have surgery to be able to actually remove it. But sometimes they're so large that when the body starts to be able to actually shrink, or when the protocol starts to shrink the tumor, sometimes you need to just get it out because you don't want it to be able to continue to be a necrotic tissue that's there and dead tissue. And so you need to be able to surgically remove it. But this is where you can utilize it with surgery. Again, many times we actually try to avoid many things like radiation, just because, again, I think that radiation, there's better targets to be able to treat it. We can talk about SIPI and what we do with our SIPI procedure, because this is really where, instead of utilizing radiation to kind of spot, treat, and target, there's so many side effects with radiation that you get because you're getting the radioactive fields that you'd want to try to target the lesion. But you also, just with radiation itself, as much as you try to target, there is going to be collateral damage on radiation. So it starts to, if that lesion is in the breast tissue, and it's close to the surface of the wall of the chest where the lungs are at. Again, the unfortunate thing is yes, you can treat the actual lung, the tumor where it's at, or where it's been removed with radiation, but you're also going to get some scarring that's going to be more of the, years down the road where you're starting to be able to create more lung scarring as a result of that radiation that you've been exposed to. So you try to limit the collateral damage, but it doesn't always work. So this is where, when we look at other therapies to be able to help maximize the actual care, to be able to avoid things like radiation, which oftentimes we do, we use therapies. And again, one of them is what's called, we call it, again, SIPI, or chemo-immunoprecision injection, where you're using these genetic target chemotherapies and the immunotherapies, and you're actually directly injecting it directly to where the actual tumor is located. And we've seen some profound benefits with that. One, we are able to utilize lesser agents and lesser chemotherapy and immunological agents as a result of that therapy, because it's going directly into where the tumor is at. Some other really neat things that we see with it, though, is that when you stimulate the immune system with that direct injection, you also are showing the body that if you have other targets, if you have other tumors in the actual system, when you are training that tumor, when you're training the immune system to go after that tumor, then you start to be able to see the immune system start to understand that is a diseased tissue. And then it starts to be able to essentially stimulate the body to be able to actually go after those other tumors or those other circulating tumor cells elsewhere in the body, and starting to be able to create almost a teaching of the immune system where to be able to attack. And so that's been a really exciting new development in our care as far as being able to directly target the tumors. It is interesting that many times people don't understand the fact that when you give a high dose chemo in an IV, how much of the chemo do you think actually gets to a tumor?
I don't know. I have no idea.
It's very minimal. It's actually, the data shows that it's about 5 to 7% of that actual chemotherapy gets to tumors. And so it's an interesting dynamic, because if 5 to 7% is getting to a tumor, and yet many of the actual chemotherapy is still going into the actual bone marrow, suppressing immune system. It's going onto the GI tract to be able to inhibit the ability to be able to eat and function. It's going to the brain for chemo brain, or heaven forbid, it goes to the actual heart to be able to create cardiotoxicity. This is where we start to be able to do minimum dose. And that's really where, again, you start to be able to see even with what we talk about as far as, yes, it needs to be genetically targeted, but it also we can use a fractionated dosage of it. So we can give a minimal amount of dosage of that actual chemotherapy directly delivered, where you get 95 to 100% absorption of the tumor, and you don't have those other symptoms and side effects of having so much chemotherapy that it's going elsewhere without actually killing the cancer. And so it's been beautiful. It's been, a really profound way to be able to treat these stage 3, stage 4 cancer patients, to be able to see that these options exist. I'll give you this example though. I was going to say, it's unfortunate to see we have so many cases that sometimes they'll be referred to hospice to be able to say, well, I had a 70-year-old male a couple of years ago who was referred to hospice. And he said, again, there's nothing more that I can do. You were early, he first got diagnosed. The cancer was literally littered everywhere within his body. And the actual oncologist told him, I think you're better off to be able to go to hospice because it's just not worth your time. It's going to have too many side effects. And within 2 months, again, your life expectancy is 2 months with or without cancer or with or without treatment. And it's just not worth it. You've got too much disease. Well, he had a friend who had known about us and said, again, I responded incredibly well. You need to go check these guys out because unfortunately, too many times do people make decisions based on insufficient amount of data, especially when it comes to their own healthcare. And so what we did was we took that patient and we actually saw some amazing targets for him. We get him on a treatment protocol and within 2 months, he was in completely cancer-free. He's still with us today. And so this is where when you start to see that when you have target that are available, they're maybe not on label or the best as far as your actual, what is that insurance company is going to cover, but you start to see that they're actually beneficial. This is where you start to be able to see breakthroughs. And in that, for that patient, it's all worth it, obviously, because his life is worth it and those outcomes are worth it. So this is what we do to be able to really make sure that we're not being pigeonholed in that insurance-based model.
How are you able to do this even in the face of standard of care? These other things, use drugs off label, et cetera.
Oh, yes. One of the things we do it because, again, Arizona is a very free state for medical freedom. And so we actually have specific licenses for integrative practitioners and the ability to be able to actually practice legally here in the state of Arizona. And that's one of the reasons that we're located in Scottsdale, Arizona, is that we have that freedom to medical practice with patient consent and be able to actually inform patients. The other way that we're able to do it is we do cash pay practices for the last 25 years as we've been building these programs. And we also have gone into actually building our own. Again, we have various insurance plans that utilize self-funded companies because what we also found in 2020 is that when it came to cash pay, we were doing all this work and we had these outcomes. And yet what we were seeing is that when we actually ran the data for cost, we actually found that in third-party actuarial data, when compared to the conventional standard of care model, we were actually half the cost of the conventional standard of care model. In that case that I was sharing with you about the lung cancer patient, again, if he were to go through his therapy, it was about $800,000. With us, it was $150,000. So you saw that actual strong amount of discounted. And it's expensive for when you're going through that. But when you see the comparative in what we're currently doing, so what we've done from 2020 to now is we've created these programs for self-funded plans that are actually 20 employees or greater to be able to self-fund those plans to have access to this kind of care. And we're seeing companies, which is usually where healthcare is being, the benefits for health insurance are being received across the country. And they're now adding this kind of level of care onto their plans. So it's cost effective.
Yeah, beyond the cost, how can some of these things be used if they're off label or if there's tons of extra compounds that weren't contemplated in the clinical trials that set up the chemo, let's say? How is it that medical boards are okay with, again, all these additional substances, even if it is cash pay?
Yeah. So specifically in the state of Arizona, we've got multiple licenses as far as this goes. So boards, when it comes to off-label utilization, and we're all within the actual scope of our actual license, in which, at Envita, we have a very much an integrative team of MDs, DOs. We've got naturopathic physicians, nurse practitioners, and we have a lot of pharmacists on our team as well. But we also have a license that's here in the state of Arizona that allows MDs and DOs to be able to pursue integrative medicine. And this is called the MDH licensure, the Medical Doctor of Homeopathy license, that actually is an integrative medical license. And so that's why in the state of Arizona, it's a very powerful state for the ability to be able to serve and treat patients. And it's legal to be able to treat people with off-label use medications with informed consent. So that's really, again, the model that we pursued here at in our Center of Excellence and seeing the results.
Oh, that's excellent. I guess this is maybe a small example. I spoke to a fellow that instead of using just, let's say, tamoxifen, for certain cancers, he would use extracts of the actual plant that tamoxifen comes from. And he said there was like 17 additional compounds. When they would administer that, for instance, it had better effect than just tamoxifen alone. So it sounds like you're doing that, but writ large in a lot of different areas and, with a lot of different adjuvants and natural compounds as well.
Yeah, I think you're absolutely right. I mean, it's a very similar approach as far as that goes, but it goes so much deeper, because obviously that's just if you're thinking about it from a natural standpoint, trying to be able to go to the natural ingredients that cause that they made the pharmaceutical companies from. And I think that's about 80% of our pharmaceutical companies come from herbs and from botanicals from our environments, right? But again, this is where it's more than that because it's just saying, again, I want to know. I don't mind pharmaceuticals. I love the pharmaceutical aspects when they actually have the best approach. Sometimes there isn't a pharmaceutical that does this, so you have to go with more of a natural agent to be able to actually silence that. Then the question is when you do that and you're silencing those actual molecules, then you want to actually, it's good to be able to do it on paper, but you actually want to get those molecules specifically to the tissue of target, whether it's the GI tract not absorbing it well. So you try to be able to look at how do you actually increase absorption across the GI tract, or if you do it to be able to actually get it targeted specifically to those actual locations of the actual tumor so it can be assimilated and utilized by the actual tumor. I'll give this example. Patrick Shun, who now is the amazing researcher, he did that with the pharmaceutical drug Abraxane, and he did phenomenal. He's now he's the owner of the periodical over in California. And so, but he took paclitaxel and attached an albumin molecule to it to be able to help absorption of the paclitaxel to tumors. And again, it's a medication that he made a lot of money on that actual medication specifically for breast cancer. But again, we need to think deeper into these. I always encourage people thinking deeper into the way in which you're being treated, because you do want to be able to not just say, yes, the medication is a good target. That's the first side. Again, we're not even utilizing that in a lot of oncology right now to be able to genetically target it and say, this is the best chemotherapies because I have done the work to see that it's the target. But then once you do that, then you want to see, how do you actually get it? What's the best way to get those targets directly to the actual tumors to have the effect that you're looking for? So again, when patients' health is the outcome and you're looking at that, yes, we want to be able to dot the T's or dot the I's and cross the T's when it comes to the legal and making sure everything is absolutely in the actual ability to be able to do this for patients. But then when you do that, again, you're seeing the outcomes are really reigning supreme. And when you do that, the technology exists. It's just a matter of unleashing it and getting it to the actual patient tabletop. It's really exciting.
So are you able to, let's say, put people in permanent remission? Like, how good are the outcomes in some cases?
So not everybody, one of the things I always make the claims of is, as far as, again, everybody's different. And so when it comes to this, but we've taken, again, these, one of our oldest patient so Dr. Prada started this 25 years ago. And our oldest patient now she started being treated at the same time, that same year that Dr. Prada opened, she's still alive with us today. And so this is where she had colorectal cancer, and she's an amazing advocate. But again, you start to see that, and it's one of those areas where everybody responds differently as a result of unique personalized medicine, and everybody has different biomarkers, targets, immunity, and reasons why. Even oncology, there's different reasons why people have cancer. Maybe it's genetic, maybe it's an environmental carcinogen, maybe it's an environmental infection that's caused the actual cancer. We actually run that and we fully extrapolate that information too. But this is where when you start to be able to see the response, the first thing for a stage 4 cancer patient is you want to start seeing responses. And then you start to be able to look at, okay, now it's getting closer. Now it's getting closer. Now you want to be able to have remission. We've gained remission. And now you want to be able to actually create that actual long-term cure. And so I always like to say that, again, I don't really like the term cure, only because of the fact that, again, if your environment was such that caused cancer in the past, again, you don't want to just go back to that same environment, eating the same garbage diet or being exposed to the same carcinogen. You do want to be able to actually recognize that if your body was a precursor to cancer before and you were in that environment, then don't go back to that same environment. You want to be able to shift things a little bit. So again, this is really where you start to shift behavior and you start to be able to have that different diet, and you continue to be able to check in and make sure that, again, the immune system stays healthy so that it is long-term remission. And again, for that individual that's, is coming upon 25 years, it's really, being in remission. Her diet and lifestyle is so different, than it was in the past. And this is where she's continued to be able to maintain her health. But again, it's one of those areas where you want to keep maintaining your health and be a pro-healthy environment in your body instead of being a pro-carcinogenic environment. What's really interesting is that you can run that data to be able to make sure that all the biomarkers are trending towards being pro-health instead of pro-cancerous. It's really interesting right now in what we do with a lot of our actual companies that come on in that we're managing in their healthcare plans is that we actually also have we use the same data and information that we've built over the last 25 years when it comes to these really complex diseases, but we've actually put forward to be able to prevent disease and put forth screeners. So what's really interesting is that when you actually look at the data, you can run your blood work, and instead of just looking at your chronological age, we actually have algorithms that actually look at what is your biological age. So maybe you're 60 years old, but you're running around with a biological age because you've taken care of your body and you've actually done some of this actual work to be able to be 15 years younger in your biological age. Maybe you're 60 years old, but you're living as a 70-year-old, and that's a real concern. And we want to be able to actually do some interventions or diet, lifestyle, and supplementation and recommendations of specialized, whether they be medications or where you're actually seeing these triggers that are creating an elevation in your biological age, to be able to really start to be able to be motivated to bring that down. And that's been huge for some of these employees, being able to have workplace actually being, having a culture that is designed around, being able to lower your biological age and taking your life back. And then you start to be able to feel better and have less sick days and things like that. That's been a real huge thing that we've been doing in the last couple of years. That's been, again, it's been really exciting to me, because it's always easier to be able to say it's easier and cheaper to be able to treat disease before it actually gets to the full blown cancer. Really nice. I feel like that's the movement that I'm really moving forward to. Is it's great to be able to treat cancer patients, but to be able to actually prevent them, you're just able to save so much more cost and improve the outcomes when they don't even get it in the first place. Really neat ways to be able to do that.
I was going to ask, is your treatment plans, are they more efficacious in the beginning of someone's cancer if it's caught early, or is it, applied just as well to any stage? Like, what are you seeing with your protocols?
Oh, it's a great question. And yes, it's always easier when you're, one early stage disease, when it hasn't spread, is always the easiest. That's just easy. Again, I always say, yes, you can cut it out, or we do things to be able to cryoablate it, where, again, maybe you're a candidate for cryoablation, meaning that, like, when you go to the dermatologist, you can freeze it off your skin. What we do is under Vagan imaging, we can actually go in and freeze it off. And then instead of going through a full tumor to be able to remove it, but still you got to figure out, where did it come from, So it's much easier to do that. And that's not hard to do. But I always like to say that I think a lot of times people are missing the mark, because it's interesting. We hear about carcinogens. Carcinogens are what? The definition of carcinogen is a chemical toxin that causes cancer. Everybody knows carcinogens as far as usually has an understanding of it. But yet when you go into an oncologist, or you have breast cancer, for instance, you oftentimes don't get asked, well, what is the actual carcinogen that could have potentially had been in my environment that's caused this actual cancer? And we know there's plenty of carcinogens out there, especially with herbicides, pesticides, and unfortunately, female golfers have a higher incidence of breast cancer than non-female golfers. And we see this in the actual R data when we run these carcinogens of herbicides, pesticides, and you have a 95th percentile of exposure and a 95th percentile level of chemical exposure to that actual carcinogen. Well, again, this is where it's an opportunity to be able to, yes, remove the cancer, treat the cancer, but then it's an opportunity to be able to remove that gasoline on the forest fire, so that the body can actually gain and stay healthy, and so that it doesn't have the risk also to be able to metastasize even in the future. And if you do remove it, again, there's a reason that you have to keep coming back to the oncologist to be able to rescan. We always like to say, again, check the circulating tumor cells, make sure that it really hasn't spread, even though you're not seeing it on an image. You want to be able to check the blood and look at it under a microscope and make sure that there's no circulating tumor cells or evidence of it spreading. And then you also want to be able to treat it with being able to clear out the carcinogens that were the root cause in the first place. Again, you don't want to keep those in the body, because it's not going to just be cancer risk, but it's a sign or a symptom of something else going on. Then you can actually make sure that your body is continuing to be made healthy, because those carcinogens, oftentimes they do affect the neurological system. They affect other areas of the actual endocrine system and the immune system. So you want to be able to actually rid yourself to be able to be preventative on that. And that's just, again, it's kind of common sense. But when it comes to even patients that are late stage, what's interesting is that even I've had patients where they've kind of failed everything, and they've tried everything, they failed it, they're looking for clinical drug trials, and then we're still able to actually do something with those individuals, because they have targets that were never tested, they haven't tried it. And so I always say it starts with the actual testing to see if you are actually a candidate to be able to move forward. But again, if you can do this process before your actual come down with those high dose chemotherapies and things like that, the high dose chemotherapy is just continuing to suppress the immune system, starts to be able to wage war on the body in very problematic ways that, again, even though it's going to maybe start to be responsive, at least early on in the stage 4, cancer process, you don't want it to be starting to kill out these other systems of the body that make it more challenging. So I always say, again, get better information and known information consultation before you start the actual journey. Get a second opinion as far as that goes. What's interesting, even with our population too, is that one of the studies that we did on our patient cohorts that we have was that 90% of our patients, when they came on out to see us, had been prescribed or were currently on medications or chemotherapy that were showing resistance. So 90% of the medications that the patients were on were resistant. And there was only 10% that had a full plan that actually was fully good for that actual patient's cancer. And so for us, it's one of those areas too. If you even have 1 out of the 3 chemotherapies that are showing resistance already, then we may want to consider shifting that regimen because it's only going to produce more harm and not actually produce the good. That's what our algorithms are built on. And it's a really profound thing when you actually start to use common sense and you start to put it in the greatest of technology to be able to find the best technology and to be able to let the patients be able to run that technology and then build your treatment plans based upon that technology and the actual evidence that you actually find. It becomes very profound.
Well, very good. How can people that are listening that, unfortunately are facing cancer themselves or know someone that is, how would they make it to your clinic? Can they go directly? Do they have to go through the doctor? What do they need to do?
Yeah, they can go directly to us. And again, the best way to be able to find what we're doing and be able to find our contact information is on our website at Envita.com. That's ENVITA.com, Envita.com. And if they're interested in businesses, being able to look at healthcare costs and being able to reduce down your healthcare costs, and how do you actually do this and have these kind of things covered in your actual healthcare plan, you can go to EnvitaHealth.com to be able to learn more about different ways that we can actually help evaluate your healthcare plan and add in these actual therapies that can improve your employees' overall health and to be able to reduce costs.
Well, very good. John, thanks so much for coming on the podcast. I appreciate it.
Hey, thanks for having me. Have a wonderful day.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.